So previously we had left off talking about the treatment options for TB. When TB is deemed multi-drug resistant or MDR resistant TB, this represents a really difficult kind of treatment approach. And so it's strongly associated with poor adherence to treatment. And so these drugs are not pleasant by any means. And so, and they also typically are given for long durations, 6 to 9 months. And so patients that have immunosuppression, patients that are just sick for a variety of reasons, prescription error and so forth, all these contribute to the development of multiple drug-resistant TB. And so resistance to isoniazid, rifampin is really problematic. And so there are specific regimens that exist. Those are described in more detail on this slide, and you don't need to know them. I just want to basically demonstrate that these regimens are out there, and there's kind of a stepwise approach to managing these patients as they kind of progress through the disease, and if the first line therapy is unsuccessful. So this is kind of a typical flow chart in terms of kind of how you'd go about kind of treating these patients. And so you can summarize this, or you can review this in more detail by yourself. But this essentially is just basically summarizing the concept. And so here's kind of where we were initially, starting with kind of the first line therapy, and then adding second line therapy as these drugs either are no longer administered for a variety of reasons. Either the patient can't afford them, the patient can't tolerate them, they become allergic, they lose the prescription, etc. And so then you can kind of see as multiple drug resistance kind of increases, then we go into the third line therapies. And so, and much higher doses, I should point out as well. And so there are varying degrees of resistance, of course, and so there also is an extensively drug-resistant form of TB, which is really problematic. This persistent form of TB is resistant to almost all drugs that are known to treat TB, demonstrating resistance to at least isoniazid and rifampin, as well as any fluoroquinolone, and at least one of the second-line therapies. And so the treatment options that exist are obviously going to be much more limited, but also much more aggressive and much longer in duration. Look at this. This is 18 to 24 months of at least 5 effective drugs just to rid the patient of TB. There is, of course, latent TB. And so the first line is isoniazid for 9 months, which is itself kind of unpleasant. There are drug-drug interactions with isoniazid, and of course there's also the potential for hepatotoxicity. And so this is, routine monitoring of liver function tests to make sure that this drug is not causing liver damage. And of course, we had already talked about special populations and even a higher risk of hepatotoxicity in those populations. Bordetella pertussis has some treatment options. Typically, first-line therapy includes macrolides, looking at azithromycin and clarithromycin, because those two in particular offer better oral absorption or better oral bioavailability than some of the others. Second-line therapy includes trimethoprim and sulfamethoxazole. Of course, we're also co-administering other drugs too. You can also think about co-administering an antihistamine. You can talk about co-administering beta-2 agonists such as albuterol or salmeterol to kind of help with the kind of persistent cough that may develop in many of these patients. Treatment options for Haemophilus influenzae. You can kind of subdivide the treatment options based on whether or not the bug is able to produce beta-lactamase. For the bugs that did not produce beta-lactamase, the first line and quite effective therapy is penicillin, particularly amoxicillin. For drugs, for bugs that can produce the beta-lactamase enzyme, of course, you don't want to use a penicillin, of course. You can look to more second or even third generation cephalosporins, the co-administration of clavulanic acid to kind of shut down beta-lactamase activity, or just go right to the second line therapy, fluoroquinolone, doxycycline, or aminoglycosides. And so these are the main antibiotics for pneumonia, with also a special emphasis on TB. This is kind of where we have historically always taught TB is in the lung infection case, so to speak. And so this is kind of a review of kind of the treatment approaches that exist. I don't need you to memorize first line, second line, third line, and so forth. This is just kind of FYI for your kind of clinical reasoning. There's no there's no way to kind of clinically reason why these drugs are first line, second line based on their mechanism of action. It's really kind of based on clinical outcomes, evidence-based medicine, clinical trials, and so forth. But just in terms of how we talk about them, we refer to them by their mechanism of action. And so you can't really logically kind of deduce any of this. This is all just based on outcomes and clinical medicine and evaluation of the literature. And so this is constantly changing. I'm not going to ask you what's first line, second line, third line, and so forth, but really just to kind of put into a framework all of the antibiotics that can be used to treat lung infections. And of course, we went through probably 2/3 to 3/4 of the antibiotics out there. We'll just keep using all of these antibiotics as appropriate. And we also briefly touched on some of the antibiotics that are specific to Mycobacterium in the treatment of TB. And of course, that too was just to kind of give you a flavor for how TB infections are managed. I think you should know the 4 or 5 main drugs, main antibiotics that are used for the treatment of TB, and then understand that as TB becomes more and more complicated, we're swapping out specific antibiotics for more stronger antibiotics, and possibly ones that have a rougher side effect profile for these patients. Okay, so this concludes antibiotics for pneumonia. This is the second part of the lecture. And again, if there's any questions, please email. Thank you.